Hello everyone, a warm welcome to the part 2 video of adreno-cortical disorder, and here we are going to see hyperaldosteronisms. First we see two types of hyperaldosteronism. One is primary and the second one is secondary, and here we also see the various causes of these primary and secondary hyperaldosteronisms and what clinical features we can appreciate from these um, causes of hyperaldosteronism, and also we see the morphology, both gross as well as microscopic features. And let's begin with introduction. Here we say this hyperaldosteronism is a group of closely related conditions and that has been characterized by chronic excessive aldosterone secretions, and we know that aldosterone has activity on the renal tubules like um, distal convoluted tubules, where it results in sodium retention and water reabsorption, resulting in the increased blood volume and plus normalizes the level of the sodium in the plasma. These things happen, but if it is secreted in excessive amount, then this became hazardous to our health. And it may be primary or secondary based on the cause and various other whether it is renin-angiotensin dependent system or independent system. Based on that, it has been classified as primary or secondary. So let's begin with primary hyperaldosteronism. Here we say there is autonomous overproduction of aldosterone, and we know that for the secretion or the production of aldosterone from the zona glomerulosum, we need two stimulus. First is renin, that is secreted from the renal kidney, and next the level of the potassium in the plasma. So these two things help in the production of aldosterone from the zona glomerulosa. But here in primary hyperaldosteronism, so there is no renin stimulated secretion of aldosterone in the zona glomerulosa. That means there is autonomous overproduction of aldosterone, and this provide a kind of inhibition, feedback inhibition to the suppression of renin-angiotensin system. As a result, plasma renin will be decreased, and this process is also called as renin independent. And the various causes of primary hyperaldosteronism could be like bilateral nodular hyperplasia of adrenal glands, and this accounts for about 60% of cases, and this is the most common cause of primary hyperaldosteronism. And next could be like Cone syndrome, which accounts for 35% of cases, and that is also called as aldosterone secreting adenoma. And next could be like familial hyperaldosteronism, that is where we can see overactivity of the aldosterone synthase gene, um, which account for the hyper production of this aldosterone, and there could be mutation in the gene like cytochrome P11 P2. And next we see bilateral idiopathic hyperaldosteronism, which also accounts for primary hyperaldosteronism. Here there is bilateral nodular hyperplasia of the aldosterone secreting cells of the zona glomerulosa, and this occurs in mainly older individuals, and that accounts for 60% cases, and most are sporadic one, that is that has no relation with the familial hereditary. And also there is germline mutation in KCNJ5 gene, which encode for the potassium ion channel protein, that is GIRK4, which we see in later part. And here what happens, that there is mutation in the potassium ion channel protein, where when this mutation happen, then this channel becomes insensitive, or that becomes non-specific to various ion, and that results in disruption of the ion homeostasis. Such types of subtype which harbor the germline mutation in the KCNJ5 gene, that is called as uh, familial hyperaldosteronism 3. And patient with such a variety of bilateral idiopathic hyperaldosteronism has less severe hypertension, And here in the picture you can appreciate that the most common cause is idiopathic hyperaldosteronism, and the second most common cause is adenoma of the zona glomerulosa, and they both results in increased aldosterones and results in excretion of the potassium and sodium retention along with the water reabsorption, resulting in increased plasma volume, and that eventually lead to hypertension. And next we see adreno-cortical neoplasm. Here, either aldosterone producing adenoma or rarely adrenocortical carcinoma are present. And this account for about 35% cases of primary hyperaldosteronism, that is caused by a solitary aldosterone secreting adenoma, that is constituent that we discussed earlier. And the common age group is mid adult, and this affect more commonly to the women, and that ratio is 2 is to 1. And 50% harbor somatic mutation of KCNJ5, and this gene encode for GIRK4, which is a type of potassium channel protein, and that is expressed in the zona glomerulosa cells. Once this mutation is harbored in the patient, then that results in the loss of selectivity of the GIRK4 to the potassium, and as a result, there will be a non-specific influx of the sodium and subsequent calcium-dependent activation of the aldosterone synthase enzyme, which is a most crucial enzyme for the synthesis of the aldosterone, and that results in over synthesis and overproduction of the aldosterone. Because uh, earlier we had seen that potassium is the stimulus for the potassium and renin is the stimulus for the synthesis of the aldosterone, but due to mutation, somatic mutation of the potassium channel protein, which is expressed mainly in the zona glomerulosa cells, the selectivity of JRK4 to potassium is lost. That means that become non-specific and begin to respond to other ions as well, like the sodium and calcium. So these two, sodium and calcium, also begin to activate the aldosterone synthase enzyme, and that's why that will also results in over synthesis and overproduction of the aldosterone. And other mutation that results in disruption of intracellular ion homeostasis are like CSENA1H mutations that encode the calcium channel protein, and such types of mutation is also harbored in those patients who are suffering from the familial hyperaldosteronism subtype 4, and also ATP1A1 mutation. In this gene encode sodium potassium exchanging ATPase, and all these result in chronic state of depolarization and results in autonomous synthesis of aldosterone. And next we see familial hyperaldosteronism, and this accounts for about 5% of cases of primary hyperaldosteronism, and four distinct subtype of familial hyperaldosteronism is seen. And familial hyperaldosteronism type 1, here we can see rearrangement of cytochrome P11B2 which is present in the chromosome 8, that begin to act under the control of ACTH. And initially we had seen that aldosterone synthesis and production is independent of the ACTH, but uh, due to rearrangement, this began to work under the control of ACTH, and thus this will stimulate the synthesis of aldosterone uh, by the activation of aldosterone synthesis from the chimeric gene. And this type of rearrangement can be suppressed by dexamethasone, which suppresses the ACTH, and consequently that will inhibit or that will reduce the ACTH dependent activation of this aldosterone synthesis, resulting in the reduced aldosterone synthesis and production. And familial hyperaldosteronism 3, we can see there is a potassium channel protein mutation. And also in familial hyperaldosteronism type 4, we can see there is a CACNA1H mutation that we seen earlier. And secondary hyperaldosteronism, secondary one that results from the activation of the renin-angiotensin system, where aldosterone is released in response to the hyperactivation of the renin-angiotensin system, and this is characterized by increased level of plasma renin. And this was decreased in case of the primary hyperaldosteronism, since that was autonomous hyperproduction of the aldosterone due to the activation of this renin-angiotensin system. So this can be encountered in association with decreased renal perfusion, example like arteriolar nephrosclerosis, renal artery stenosis, and arterial hypovolemia and edema, example like congestive heart failure, cirrhosis, nephrotic syndrome in such cases, where the blood volume is compromised or any other that results in reduced amount of the sodium in the blood, that all contribute for this secondary hyperaldosteronism. And also in pregnancy, estrogen increases the renin substances. And the morphology of hyperaldosteronism can be seen as like in bilateral idiopathic hyperplasia, there is diffuse or focal hyperplasia of the cells of zona glomerulosa, and aldosterone producing adenomas that present as a solitary and small, well circumscribed lesions, and that is bright yellow lipid laden cortical cells that resembles fasciculator rather than glomerulosa. That means its appearance becomes similar to those of the zona fasciculator rather than that of the glomerulosa, due to the lipid laden cortical cells which give it a bright yellow appearance. And cells are usually uniform in size, but later on they begin to show nuclear and cellular pleomorphism, and eosinophilic laminated cytoplasmic inclusions called spironolactone bodies can be seen in the patient, especially in those patients who are being treated with a spironolactone. And such adenomas do not suppress ACTS secretion. So, the tropic effect of the ACTS on the adrenal gland is not compromised. That's why adjacent adrenal cortex and contralateral gland are not atrophic. And also, we know that zona glomerulosa is a ACTS independent region, so there is no effect of such things on the cortex in the, especially in the zona glomerulosa. And also such types of adenomas do not suppress the ACTS secretion. And similarly, the clinical features that we can manifest in the person suffering from the hyperaldosteronism are that is most common cause of the secondary hypertension is hyperaldosteronism, and that mainly results from the sodium retention, and eventually this will lead to increased blood volume that we discussed earlier. And also the long-term effects of hyperaldosteronism induced hypertension are like the primary hypertension, that is present as heart failure and myocardial infarction, arrhythmias and strokes. Such things can be seen. That is also present in primary hypertension. Similarly, neuromuscular manifestations due to hypokalemia resulting from the renal potassium loss includes weakness, paresthesia, visual disturbances, tetany. This much. Thank you for having